here at Christian Medical College, Vellore. He has several memberships, lifetime memberships at the IDF, DASG, DNA, RSSTI. He is the Emergency Advisory Committee and Store Management Team member. And I welcome you, sir, on to you for your presentation.
Thank you. Thank you, Jody sir, for giving me such an opportunity to speak in the JPEF. And good afternoon, everyone. So today my topic is like must negate. Like we can't prevent the diabetes, but we can prevent the complication. And this is the one most neglected complication. Like from the doctor side and from the patient side also. We are looking our face 100 times in the mirror, but we are not checking the feet in one time. In our clinic also, we are not asking our patient to check that. So blood flow basic, like as we know, PAD is a narrowing and the occlusion of the arteries outside of the heart and the brain, and these are the like outside of these are the artery where it can be occluded. So 90% is a atherosclerosis. Rest 10% there is a like inflammation of the artery, intrinsic artery. There is a obstruction like compression, and there is a like venous flow obstruction, and there is a coagulopathy. Like global prevalence of the PAD is high, represent 25.6% of the global burden of the CV disease and 1.7 of the overall global burden of the disease. Third leading cause of the CV mortality after coronary disease and the stroke, high mortality, morbidity, disability due to the amputation. Increased risk of coronary artery event and the stroke. More than 200 million people worldwide is affected by PAD, and increased prevalence in the low and the middle income country. So age-related prevalence, like 20% have the PAD at the age of 80 years in the US. So increase of the age, it also increase. So significant unmet medical need. So identification patient at the increased risk of the PAD, like age, if more than or equivalent to 65 years. Age 50 to 64 years with a family history of PAD or risk factor for the atherosclerosis such as type 2 DM, history of smoking, hyperlipidemia and hypertension. So diabetes and smoking is the two most like high prevalence for the PAD. So age less than 50 years with the type 2 diabetes and the more than one additional risk factor for the atherosclerosis. Non-atherosclerosis disease in the another vascular bed like the coronary, carotid, subclavian, renal, mesenteric, artery and stenosis and AAA. Everyone heard it? So multiple risk factor like there is a modifiable risk factor which can be modified and is neglected. Actually, we can prevent the diabetic foot ulcer, we can prevent the PAD. The modifiable risk factor we can modify. Non-modifiable risk factor we can't change the parents, we can't change the gene like age. So that are the concern. Like another are socio-cognitive restriction and psychosocial factor like due to the poor diet and poor lifestyle and CKD and renal impairment and heavy metal radiation and injury. So risk factor for development of foot ulcer or the amputation among the patient with the PAD. History of the previous foot ulcer and or amputation minor or the major. Charpot or the other foot deformity. Diabetes with the poor glycemic control. So 1% increase in the HbA1c. So a risk of the PAD is 26%. CKD, especially ESRD, peripheral neuropathy, especially with the loss of the protective sensation. One or the callus on the feet, considered pre-ulceration, lesion in the patient with the PAD and ongoing smoking. So history and the physical examination findings history of the PAD, that history like claudication, pain type, aching, burning, cramping, discomfort of fatigue, location, buttock, thigh, calf or ankle, onset or offset, distance exercise of it, how long for the relief after the rest, like typically less than 10 minutes of typical claudication, or the non-joint related external lower extremity symptom, not typical or claudication or symptom of the impaired walking function. Lower extremity muscle discomfort associated with the walking that require more than 10 minutes, rest of the result, less leg weakness, numbness, or the fatigue during the walking without pain. Ischemic rest pain, history of the non-healing or the slow healing, low extremity wound, or erectile dysfunction means there is a endothelial dysfunction. So there is the chances of the other severe event. Coming to the physical examination, like abnormal lower extremity, pulse palpable like fever, popliteal, and dorsal spiritus, or uh, posterior tibial artery, vascular group, like we have to check epigastric, periumbilical, non-healing lower extremity wound, means there is a chances of 50% chances of peripheral artery disease, non-healing also. Lower extremity gangrene, other physical findings suggestive of the ischemic is a systematic hair growth or nail bed change, calf muscle, atrophy or elevated failure or degenerate rupture. So important to identify patient with the PAD, like 3 to 4 fold of increased risk of the cardiovascular event, even in the setting of the asymptomatic disease. At 5 years, one of the 5 patients with the PAD will experience a non-fatal CV event. 20 to 60% increased risk for MI, 2 to 6 fold increased risk of CV death, and 40% increased risk of the stroke in the patient with the PAD. So natural history of PAD typical disease progression, like asymptomatic. PAD is asymptomatic, like more than 50% is asymptomatic. Typical leg pain, like 40 to 50%, claudication 10 to 35%, and critical limb ischemia, that is 1 to 2%. So progressive function important, like 5 years outcome, limb mobility, like stable claudication like 70 to 80%, worsening claudication 10 to 20%, critical limb ischemia, that is 1 to 2%, CV mortality and morbidity, that is non-fatal CV event, MI or stroke 20%, mortality that is 50 to 30%, and 1 year's outcome, that is aligned with the 2 limb, that is 50%, and amputation 25%, CV mortality that is 25%. So these are the investigations which can be done in the like OPD visit every 6 months to the assessment to the like non-invasive investigation. We have to assist the patient in the OPD visit. And invasive, if there is a like highly suspicious, then we can go with the invasive test. So multifactorial approach to the imaging of PAD, like lifestyle modification, which we can do. We can modify the lifestyle of the patient to prevent the complication. And other is simple pharmacological therapy, and if we have to refer like for the invasive management and including the surgery if severity increase. So early stage PAD is mainly managed by the lifestyle and the pharmacology, simple lifestyle and pharmacology. Like simple, we can put the equation in the antiplatelet. So ESD 2024 guideline and the recommendation, like say first antihypertension, we have to control the hypertension, we have to control the hypertension, we have to control the lipid, we have to optimize the glucose control. Like we have to take HbA1c less than 7, 6.5 is a better. If each 1% increase the HbA1c, chances of PAD increase of the 26%. So and antithrombotic drug, that aspirin and clopidogrel. 88 2025 guidelines and recommendation, that is SGLT2 and GLPRA with demonstrated with the CV benefit recommended with the reduced MACE. So combination with the SGLT2 with the demonstrated CV benefit of the GLPRA, demonstrated CV benefit may be considered of the additional CV and the kidney outcome benefit. So this is the 2025 recommendation of the ADA. When to refer the case, like when we have to refer the case from our OPD to the vascular surgeon or from the primary care to the tertiary care. So if there is a critical limb ischemia, sign like ulceration, non-healing ulcer, rest pain and gangrene. ABI that is less than 0.70 or significant abnormal TBI. So rapid symptom progression of the functional decline. So why early referral matter? Like PAD after the 10 to 20% of the adult over the 60% globally, often underdiagnosed lead to the MI, stroke, limb loss if untreated. Diabetes are at especially high risk. Delayed presentation common due to the neuropathy. So these are the red flag signs. Therefore, if you notice intermittent claudication, that is leg pain on the walking, rest pain, non-healing foot ulcer, gangrene, that is critical limb threatening ischemia, diabetic foot wound, especially with the poor healing or infection. So these are complications like patients with the PAD are at high risk of the major CV event, MI, stroke, and the death. Limb-related complications include blood clot or the emboli, lower extremity ulcer, gangrene, and need for the amputation. So prevention still is better than cure. Actually, we are forgetting to prevent the disease. So prevention of the PAD, treatment of the coexistent medical condition like diabetes, we have to control the diabetes, we have to control the dyslipidemia. Like 100 is better, but if there is a history of PAD, then 70 is recommended. Earlier 70 is recommended. Lifestyle modification like exercise, healthy diet, smoking cessation, and weight loss in case of the obesity. So these are the recommendations from the Diabetic Food Society of India for the vascular evaluation and treatment. Very simple and very important. All patients with the DM event without a foot ulcer should undergo complete clinical vascular evaluation every 6 months. Every 6 months. ABPI should be done as a part of that there is non-invasive, which can be simply done in the OPD basis. So initial examination to the defensive arterial claudication from the neurogenic or the venous claudication. All patients with PAD should have baseline laboratory study with including ECG and the lipid profile. The abnormality should be addressed and treated. Doppler ultrasound is recommended as the first line modality in the patient with the claudication under the gangrene. The scan should be performed by the experienced sonologist. Angiogram, digital subtraction angiogram, computed tomography angiogram, and magnetic angiography should be done only after a just clinical evaluation. All patients with the intermittent claudication should be placed on the supervised exercise program, lifestyle modification, control of the risk factor, and the appropriate pharmacotherapy. Like patients who develop disabling claudication or the rest pain after the adequate medical therapy need to be treated early and aggressively by the vascular surgeon. So, watch and wait policy in the India, usually Southeast Asia country, after development of an ischemic lesion, often result in the increased mortality and morbidity and the cost to the patient. So, treating the diabetic foot ulcer is more costly than the cancer. It is the worst with the cancer. So, do not amputate if you can help the limb. So, these are the summary. Prevent of the PAD continue to increase worldwide. It is the prevalence of the PAD continues to increase worldwide. It is important to identify patients with the PAD because of the increased risk of the myocardial infarction, stroke, and the CV death and impaired quality of the life. Despite effective therapy to the lower the cardiovascular risk and the prevent progression to the critical limb ischemia, patients with the PAD continue to be under recognized and undertreated. Management of the PAD patients should be include an exercise program, guideline-based medical therapy to the lower and the severe risk and the devasculation, and when indicated, statin and the dual antiplatelet therapy are a part of the guideline based on the medical therapy. Potent statin like a rosuvastatin, aspirin, clopidogrel can play an important role in the imaging PAD by the reducing pill burden and improve compliance. So, in OPD, few minutes for the kids. We have to give a few minutes for the kids for the healthy kids. So, less our patient, like less our diabetic patient, natural death can will occur with the 2 feet. Thank you.
Thank you very much. That was a wonderful presentation. If anybody from the audience do want to ask something. Most of the time that we end up doing a toe Doppler or the other duplex ultrasound, but the toe Doppler, most of the time, most of the diabetic patients will be having less than 0.7. But when we send them for a duplex ultrasound, all that we are able to see is a diffuse atherosclerotic changes, most probably today, even after the Covishield and the Covaxin vaccine as well. So when do you want to start a silostatin in one such individual? And the second option is, what is your personal experience with rivaroxaban and PAD? And when do you want to start a rivaroxaban in a diabetic patient with a PAD?
If you are done the Doppler, if there is a finding the Doppler, you can start with both.
Doppler with only a vascular insufficiency or a blockage?
No, vascular insufficiency.
Insufficiency.
Yeah.
Even if it is a trifasic flow with all
Yeah.
the arteries, still you want to go ahead with rivaroxaban and silostatin.
Early start.
Even with the mild insufficiency.
Yeah.
Thank you, sir.